I have to be honest, I think the CKM cardiovascular kidney metabolic syndrome guidelines are probably one of the biggest practice changing and paradigm changing guidelines that we've had to date. In fact, it's really, if you think about it, pretty mind blowing because it's the creation of a new disease syndrome. And what it really does is it breaks down the barriers that we've had, the silos that we've had in medicine for so long, where we really have the cardiologist treating the atherosclerosis, the endocrinologist treating the diabetes, the nephrologist treating the chronic kidney disease, and the primary care treating the obesity metabolic syndrome and kind of coordinating care. So it really does unify all of those specialties together and brings up this interdisciplinary approach. And I think it's made some important contributions to thinking about cardiovascular risk. So the first and most important is that it helps us to detect risk earlier. So it really changes that paradigm of waiting for that plaque to rupture, waiting for the heart attack, the acute coronary syndrome, the cerebrovascular event, and then doing something. But instead, it now thinks about detecting risk earlier using more sophisticated risk tools. It also helps us to stage disease across the lifespan. This to me is really important because we're making analogies essentially between cardiovascular disease and cancer, which we are very familiar with staging, but we've not really thought about staging cardiovascular disease. Now, granted, we stage heart failure, but that's a little different because again, there the disease already happens and then you think about staging it. But here you think about staging across somebody's lifespan. So I could have, a 19-year-old in my practice who's obese and has prediabetes, and that person already has stage 1 cardiovascular kidney metabolic syndrome. So it really does help us to think about someone's risk, not necessarily waiting for that ASCVD event. We also use the guidelines as a way now to think about this staging as a way to categorize people's risks so that we can match the therapy according to the stage of the disease. To me, that's a really clear framework of sort of thinking about how to put somebody on which therapy. Again, you're not nebulously thinking, oh, okay, maybe this person will benefit from an anti-obesity medication, but you're actually putting them into stage 0, 1, 2, 3, 4 CKM, and then deciding whether or not it makes sense for them to have therapy. And the advantage of this really is that it can prevent progression, of course, but in some cases, even enhance regression, essentially move somebody from stage 1 back to stage 0 if obesity was the biggest driver of stage 1. So the fact that it's breaking down these walls in medicine, that it's made us think about this sort of new disease paradigm and really staging heart disease like we stage cancer, I think it's been a tremendous contribution to the field of preventive cardiology. I know one thing for certain. I'm changing my approach to screening based on these guidelines. And again, now the emphasis has become to stage every patient that walks into your clinic's door, no matter what they're there for, PVCs or anything else. And then you can really match the screening according to the stage of disease. So you're not just using this one size fits all for people who may have different risk factors or maybe different stages of their CKM journey, but you're actually matching the screening. So, obviously in stage 1, you're going to do screening maybe, at stage 0, you're going to do screening maybe every 5 years where you're just kind of looking for trouble essentially. And you're going to do the usual metrics, the BMI, the kidney, the blood pressure, but also waist circumference, which has really risen to the top. In stage 1, once they already have, obesity or they have some other manifestations of having cardiovascular kidney metabolic syndrome, you're perhaps going to do more frequent screenings, maybe every 2 to 3 years. And you're going to think about adding more kidney markers. So that's the other thing in screening. We've really now started putting more of an emphasis on kidney markers, which for me as a cardiologist, I have to be honest, a few years ago, I was not checking UACR in my patients, despite the fact that it is such a good prognostic marker of cardiovascular risk, and despite the fact that it's a modifiable risk factor for heart disease. But now that's certainly become part of my sort of usual screening armamentarium to think about albuminuria, think about EGFR, think about diabetic screening, think about staging their obesity as well. We know that obesity, depending on how many consequences or end organ damage it causes, can be in different stages too. So I don't just call somebody obese or morbidly obese, which is a term we don't use anymore, but I think about what stage of obesity they fall in. So that's partly how I'm going to change my screening. I've already been using the prevent equations for some time, but this guideline really does put a huge emphasis on that prevent calculator because it does incorporate that UACR. It also incorporates social determinants of health. Now, this is something I haven't been doing in my practice routinely, but after these guidelines, I'm going to start doing that a little bit more, which is really to assess whether or not somebody has food insecurity, whether or not they have housing insecurity, whether there's financial stressors. These are all things that are important to think about when we're thinking about comprehensive cardiometabolic risk. Now, one thing we can't routinely assess, which I think is missing even from the CKM guidelines, is a metric like air pollution, which we know is very well correlated with cardiovascular risk, but it's not something that's part of our regular screening. But certainly the social determinants of health, I'm going to start to have my patients do a questionnaire that my medical assistant can start to fill out so that I can better assess those and really be more holistic in my approach. For me, that staging is really something to anchor to. It gives me very clear guidelines as to what I'm supposed to do at every stage. So stage 0, which means you have no disease, that's the best place to be. There, I'm just focusing on screening, education, emphasizing life's essential 8, making sure that somebody stays stage 0. Stage 1, where you have, you're overweight or you're obese or you already have prediabetes, there I'm starting to shift the focus to prevention. And there I'm starting to maybe even think about, if you already have obesity, use of some of those pharmacologic medications for obesity, such as GLP-1 receptor agonists or GLP-GIPs. Because again, you want to start to address the disease early in its trajectory so that it doesn't start to manifest and develop into cardiovascular kidney metabolic syndrome stage 4, which is really what we as cardiologists are used to seeing. Is once it's already the horse is out of the barn, that's when the patient comes to us. But if you start routinely assessing patients for their staging, you find them at stage 1, you start to emphasize prevention. Stage 2, which is where they have metabolic risk factors, like perhaps they've developed some hypertension and or they have CKD, but they've not yet had cardiovascular disease, clinical or subclinical. That's that wake up call, right? That's where, okay, your train's already headed for that destination. Now I really got to take things seriously and be very aggressive about risk factor management. Whichever risk factor they've developed, if it's hypertension, for example, then you want to make sure to treat that aggressively. But you also want to, again, emphasize more screening in stage 2, because now they're headed for cardiovascular disease, having these multiple risk factors. Stage 3 is when they've already developed subclinical cardiovascular disease, or that prevent calculator tells me that they're very high risk for developing it. Both of those, to me, are the most important kind of markers. So stage 3, I would say, is the most important stage because you're on the precipice of going on to essentially have cardiovascular disease, which is stage 4. So if you find a ton of atherosclerosis on a calcium score, or, you start to put in that prevent calculator and you say that risk is off the charts, here's where we think about GDMT, guideline directed medical therapy for prevention, which is a whole new concept that these CKM guidelines have introduced to us, because for the most part, we're thinking about GDMT for heart failure, pillars of heart failure. We don't think about it for prevention. So to me, that's the most important stage. And then stage 4 is once they already have established cardiovascular disease, they have multiple CKM abnormalities. That's where that horse is out of the barn. There, you're really focusing on secondary prevention, making sure they don't go on to have a secondary event. This is another thing that I'm doing differently based on the CKM guidelines. So for the longest time in medical school and in my training, when a patient has early stages of CKM syndrome, whereas like obesity or prediabetes, we say, okay, let's focus on lifestyle, right? Let's work on lifestyle. When lifestyle fails, then we think about pharmacologic therapy. Here, these guidelines have changed that paradigm as well. And it's not a sequential approach, but a simultaneous approach. So now, instead of waiting for lifestyle to fail, you obviously emphasize lifestyle, those life's essential 8. Make sure they're eating well, make sure they're have good physical activity, their weight is good, they're sleeping enough, they're not smoking, they're maintaining their blood pressure, they're doing their best to hit those life's essential 8, but at the same time, simultaneously, you're thinking about starting pharmacotherapy for CKM syndrome. These are your SGLT2 inhibitors, your GLP-1 receptor agonists that are no longer just diabetes medicines, no longer kidney medicines, no longer heart failure medicines, no longer just obesity medicines, but a comprehensive cardiovascular kidney metabolic syndrome medication. So I really think about those two approaches as sort of occurring in parallel. And I think about the medications and the lifestyle really complementing each other to get the patient to their CKM stage faster. So if you want to de-escalate their stage from stage 1 to stage 0, I try to use a combined approach now based on these new CKM guidelines to really try to get them there faster. So, the guidelines are great. They're this beautiful document that gives us all these great things to strive to. But when it comes to clinical implementation, there continue to be challenges when it comes to implementation science. I think the biggest challenge is going to be changing people's mindset. It's really going to be the culture of breaking these specialty silos that we live in and really saying that CKM syndrome is everybody's disease. Of course, educating about CKM syndrome. I know there are a ton of specialists and even primary care physicians who may not be familiar with the terminology because it's a relatively new terminology. So educating about it and really making it so that all these specialties work together. In fact, the CKM guidelines even talk about ways in which you can appoint champions or you can have clinics that are multidisciplinary clinics that can help all of these specialties work together. So I would say that's one of the biggest challenges. The other challenge is really to think about changing workflow, right? Because all of a sudden now we're talking about screening a much larger population and screening them much earlier. So we're used to doing what we're used to doing, and we're asking people to start to screen every patient that walks into their clinic using the CKM, framework and thinking about using the prevent equations essentially in every single patient that walks into your clinic. And I think the challenge there becomes, again, workflow issues, time constraints, logistics of how really that's going to get implemented. I talked a little bit about medications and just how wonderful they can be in terms of simultaneously addressing the lifestyle as well as pharmacologic ways to treat CKM syndrome. But access to these medications, because of the cost, insurance barriers and such, continues to be a pain point for many of us clinicians. And as much as we want to put many more of our patients on these medications, I think that's going to be really difficult. And then finally, I think we talk about the social determinants of health, right? That is such an important part of screening now for cardiovascular disease, of really using that as a risk modifier to increase somebody's risk of ASCVD if they do have financial insecurity or they have housing instability or food insecurity. But what do we do about it? And so we really do need some more targeted interventions as well when it comes to mitigating the risk that comes from the social determinants of health, rather than just assessing them and saying that they're bad. We really need to think about ways to actually reduce them. But as a clinician, as a preventive cardiologist, I am so excited about these CKM guidelines because I think it really does shift the focus on being proactive rather than reactive. It talks about raising awareness of CAD and CKM syndrome in your 20s and 30s, long before we had ever thought about doing it before, because we're starting to stage every patient. And now with all these medications in our toolbox, hopefully we can start to change people's CKM trajectory, because it's staggering. If you look at the studies, they tell us that 90% of Americans are already CKM stage 1 or higher, 90%. Which means already we are behind when it comes to prevention in the American population. So I'm really glad about this guideline document. I know it's going to change what I'm doing in my clinical practice, and I hope that it does the same for you.